It's my great pleasure to introduce Dr. Catherine Sebastian, who is UCL alumni and also a well-established researcher in adolescent mental health. Kat has published a number of really important papers in adolescent social cognitive development, both how it develops normally and also about when it goes wrong in children with conduct problems and those on the autism spectrum. She spent many years in academia, most recently leading her own research group at Royal Holloway, before moving to Wellcome Trust to take up this new and exciting position as their evidence lead in the mental health priority area. And she's today here speaking on behalf of the evidence and the research side of the mental health priority area. And of course, we know that another UCL alumni, Miranda Wolpert, is the director of mental health at Wellcome Trust. And Catherine will talk about current directions at Wellcome Trust, but some of the programs are still being finalized. So she will be able to give us a heads up as to, you know, what is their current thinking and where they're going. But obviously there are some things that are still not finalized, and she wanted this to be flagged up. So I'm going to hand this over to you, Kat, and anyone please post your questions on the chat during the talk. And you can either ask them in person or I can ask the questions from the chat after Kat has finished the talk. We don't anticipate this session to necessarily run until 2:15. Hopefully we'll be finished by around 2 o'clock, but there is the option to go on until 2:15 if there are lively questions. So I'm going to hand over to you, Kat, and thank you very much for agreeing to do this.
Thanks, Essie. Thanks for the lovely introduction, and it's great to be back speaking at UCL, if a little daunting. As Essie mentioned, it's my alma mater for PhD, and then I worked with Essie for a few years as a postdoc. So it's fantastic to be back. I'm really happy to be here today to talk to you about the work that I've been doing as part of my new role as evidence lead for the mental health priority area at the Wellcome Trust, and also to talk a little bit about the general direction of mental health research at Wellcome. So just to give a brief overview of my talk, I'm going to talk about the new structure of research programs as a whole at Wellcome. That's now sort of in the public domain, and there are webinars about it, but I thought I'd just mention it because it provides some important context for the rest of the talk, and also maybe of general interest. I'll then speak more specifically about mental health research at Wellcome and what that might mean for you as a mental health researcher, and particularly as mental health researchers with an interest in children and young people. And then I'll talk about our current work. So what we've been doing over the past year to 18 months while we've been setting up the priority area at Wellcome, the work streams we've been working under, and also funding opportunities that may be coming up. As Essie says, very happy to answer questions, but probably best to leave it till the end, and Essie will chair. But if I see them in the chat and I happen to have the answer at hand, I will chime in. So in terms of the research programs at Wellcome, you'll probably be aware that there's been quite a change in the way our research programs are structured. And the way that it will work going forward is that there will be one arm of the research programs program called Discovery Research. And that's going to be a very large program of research that will fund curiosity-driven research, so really basic research that yields insights into life, health and well-being. So that will fund a lot of the sort of more basic neuroscience and mental health work that has already been funded by Wellcome. And we anticipate that there will still be that route. But in addition, we're pleased to say that mental health will also be represented in one of our 3 health challenge areas. So we're developing 3 health challenge areas aimed at significant global health challenges that we think are going to be affecting humanity over the next 30 years or so, one of which is mental health. And so our key overarching aim for this is a world in which no one is held back by mental health problems. Very topically, another challenge area is going to be infectious disease. So a world in which infectious diseases are under control. And then finally, climate change, and particularly the intersection between climate change and human health. So a world in which global heating does not harm health. I think one of the advantages of this strategy is that we're aiming to work synergistically across the different programs within discovery research, within the research programs. So for example, mental health priority area can work with discovery research and make sure that the entire pipeline of research from discovery to translation is covered. We can also look at the intersections between the different health challenge areas. So for example, as we know well, one of the largest impacts of COVID is on mental health through circumstances such as lockdown and bereavement. So we think it's a really exciting way in which we're going to be able to tackle some of these big challenges while still remaining focused on the basic discovery research, which Wellcome has funded so far. You may be wondering, what does this mean for me as a mental health researcher? So I think it's broadly good news for mental health research. So mental health research will be funded via several areas in the new strategy. So as I mentioned, there are the discovery schemes, and that's for basic research on any mental health topic. So it's very broad. Any area within mental health science is included as long as it's more on the basic discovery side rather than interventions or RCTs or scalability. And I'm not going to go into too much detail about the discovery schemes because I know that content has been covered elsewhere and far more expertly by my discovery research colleagues. But I would direct you to our website for a recent webinar on the discovery research schemes. Broadly, these have been reorganized and simplified into three separate schemes based on career stage, so early career, career development, and discovery awards for more established researchers. Then there's the mental health challenge area. So at the moment, although nothing has been 100% finalised, our thinking at the moment is that the focus for the mental health challenge area, at least in the first instance, will be on depression, anxiety, and psychosis. And we'll focus on intervention, but also mechanisms of action. And I'll talk a bit more about exactly how that might work later on in the talk. And then, of course, there are the other challenge areas, so infectious disease and climate change. And although the calls and plans have yet to be finalised, we're anticipating that there will be opportunities for mental health researchers to put in collaborative projects at the intersection between mental health and climate change, or mental health and infectious disease. So hopefully that's quite a few different opportunities that you might be able to apply for as a mental health researcher. But as I say, these plans are still in development, and it will probably be 6 to 12 months before we can give concrete information about specific grant schemes within the challenge areas. So you may be thinking, there seems to have been a lot of messages around mental health by the Wellcome Trust. Over the past year or so, we've been talking about the priority area. Now it's going to be called the challenge area. How do these different areas link together? So the mental health priority area launched in January 2020, led by Professor Miranda Walcott. And this put £200 million over 5 years to focus on interventions for youth anxiety and depression, specifically ages 14 to 24. So its focus was deliberately quite narrow so that we could make maximal impact over the 5 years with the £200 million. But alongside the priority area, the strategic changes have been happening at Wellcome, And now the challenge area is coming to expand this remit. So it will consolidate both the work that we've been doing as part of the priority area, but will also bring in work being done around Wellcome on anxiety, depression and psychosis, and consolidate that into one place. As I said, anxiety, depression and psychosis are likely to be the foci in the first instance, and we're looking at a time frame of 30 years rather than 5 to 10 for the priority area. So that really gives us a lot more freedom to think about funding longer studies, larger studies, and really having a vision for what we want to achieve over the long term. One of the things that we're thinking of at the moment is how best to bridge that pipeline between basic discovery research and translation, because this is one of the areas that we've identified is quite siloed, particularly within mental health science. Those who are engaged in understanding the more basic mechanisms, whether that's at a neuroscience level or even at a cognitive level, don't always necessarily end up communicating directly with those who are clinical practitioners or working on translation studies. So one of the problems that we'll be trying to solve is how best to bridge that divide. I think we're interested in two pathways broadly. So we'll have the discovery research part of Wellcome, which will be helping us to understand basic causal mechanisms underpinning mental health problems. And one of the things that we would like to do as a challenge area is to take that research, work very closely with our colleagues in discovery research, and work out how we can best fund research that builds on that discovery research, as well as discovery research that's happening outside of Wellcome. But then at the same time, I think particularly with mental health science, and I'll talk about this later in the context of work we've been doing as part of the priority area, we often have interventions that we know to be effective. Clinical trials have shown them to be effective and they're used in practice, but we don't necessarily always have a clear idea of the mechanisms by which they're working. And so another important part of our work is going to be reverse or back translation to try and understand the components of interventions responsible for therapeutic action, with a view not just for basic understanding, although that's of course very important, but also so that that might help us to develop more effective treatments or to tailor treatments more effectively to individuals. I hope that's given you a bit of a flavour of the sort of history of the mental health priority area over the past year and how that's transitioning into the challenge area and how we will intersect with other aspects of mental health research at Wellcome, such as via discovery research. I hope in future to be able to give you a lot more detail on opportunities available as part of the challenge area and more detail about our specific strategy. But as I said, that's all that I'm able to say at present, because we're right in the middle of planning the new strategy, which is very exciting. So watch this space. So for the rest of the talk, I'm going to tell you a bit about the work that we've been doing over the past 18 months or so, and also some funding opportunities within the priority area that are either open now or are coming up over the next 6 months or so. So the work that we've done so far as the mental health priority area is of course focused very much on anxiety and depression in young people aged 14 to 24. And we've been working broadly to 3 work streams. First is transforming mental health science. Second, unleashing the power of population data. And the third is around policy and advocacy to bring greater funding and awareness to mental health research. And I'll go into each of these in more detail. And all of these are underpinned by these 4 pillars that we think are crucially important for mental health science research going forward. So empowering individuals, including those with lived experience of mental health problems, ensuring that the best evidence underpins everything that we do, strong advocacy, and thinking about sustainability long term. So I'll talk about our 3 work streams. Most of my work on the evidence side has gone into work streams 1 and 2, but I will also talk about the 3rd, which is policy and advocacy, because it's just important to give you a flavour of the breadth that we are looking at within the priority area. Also worth saying before I go on to talking about the 3 work streams, one thing that I think we've been particularly vocal about over the past year or so is putting lived experience at the heart of our work. I work closely alongside Kate Martin, who's our lived experience and public engagement lead, and she coordinates several lived experience consultants and lived experience advisors within the team, so that they're involved in helping shape our strategy as a funder, helping to evaluate funding bids that come in, and really making sure that the voice of young people is heard at every stage of our work, and then at every stage of the research process of the researchers that we fund. And one point that Kate's often making, which is we don't just do this because we feel it's the right thing to do, we also think that in doing so, we will actually improve the science, because the research questions will become more focused on what's likely to make the most difference for the young people. They may pick up on things as service users or research participants that they've experienced previously, that their input might then improve the way that the research is done. So I think there's several advantages to this approach. And just showing, I think about 6 months ago, we recruited 17 new advisors worldwide. I think another advantage of this approach is that we get an international perspective rather than just UK. And also we've tried to diversify the group of lived experience advisors so that we have young people represented from low and middle income countries as well as high income countries. As we'll see, this is an area that we're interested in expanding, and what we've found so far is that there's less research than we would like coming from these regions. So work stream 1, transforming mental health science. We largely have thought about this in terms of 3 key problems. So one, of course, I think we all realise that interdisciplinary research is very difficult. In mental health research in particular, communities are quite siloed and fragmented. So as I was mentioning before, it's quite hard for clinical colleagues to always work alongside those from more basic neuroscience. There's often differences in the language that different researchers speak. Because mental health is so broad, it also includes many disciplines that people may not have traditionally thought of as being part of mental health science. So political science, philosophy, for example, data science. And I think its very breadth is both a great strength, but also it can be a disadvantage because it means that we're not necessarily able to harness those different voices effectively in pursuit of a common goal. So I think that's one problem in the field. Lack of shared mental health metrics. So this is an area where Miranda has particular expertise. There are so many different ways of measuring, for example, depression symptoms or anxiety symptoms, and the lack of a standard holds us back in terms of being able to compare across data sets or augment data sets. So we've been doing some work towards trying to harmonise metrics within anxiety and depression. And then gaps in funding. So I think my experience, and I think this is true of the field as a whole, is that there's been quite a lot of investment in basic causal mechanisms, and perhaps less so for interventions, and less so bridging that gulf between the mechanisms and translation, and very little research conducted in low and middle income countries. So those were the 3 main problems that we identified. And so we have 3 strategic aims aimed at solving those problems. Firstly, building a new mental health science community. So of course there is a mental health science community, and I've been privileged to work in it for my entire career. But I think what we were trying to do specifically was to bring people from different disciplines together to work on the same problem, and sort of see if that led to any changes in the way that people worked. So last year we ran a commission called Active Ingredients, and I'll talk about that in more detail. But briefly, we brought together 30 teams across different disciplines in mental health science to review the state of the science on interventions for youth anxiety and depression. And I'll tell you more about that later, but that was really interesting, different way of working for me and for the academics involved. We've forged links both with researchers, but also our lived experience experts and journal publishers, and really tried to get a sense of what are the biggest issues in mental health science to date. Some of you may have seen the work we've done with Mental Health to bridge science and practice and publicise the findings of our active ingredients work. And we recently collaborated with MQ on the 2021 Mental Health Science Summit. I don't know if any of you were able to attend, but we were really pleased with the range of mental health science represented, and also the voice of lived experience. In terms of standardising metrics, we have recently announced a recommended set of self-report measures and brought together, I think it's 7 funders at the moment, including ourselves, NIMH and UKRI. And we have agreed that where possible, we will ask our funded researchers to use 3 particular anxiety and depression measures, GAD-7, PHQ-9 and RCADS, in addition to any other measures that they would like. So we're not mandating that they have to use those only. But the rationale being that this will hopefully allow better harmonisation and comparison across different research studies. We're in the process of working out funding plans for work on measures. And we recently funded the COVID Minds Network, which runs out of UCL, which has recommended these measures to the more than 100 longitudinal studies to have joined the network. And finally, what about improving the evidence base for intervention research? Well, we're at the very beginning of this journey. We anticipate that this will be a large part of our new 30-year journey. But in the first instance, we have been commissioning reviews on the state of the science and learning from that. And also we commissioned a couple of teams to look at qualitative insights from young people around the world on what they thought about active ingredients concept and what might be missing. And this fed directly into our second commission, which is now in the process of selection. And obviously watch this space. We're currently planning future commissions and grant funding as we transition into the challenge area. I mentioned the Active Ingredients Commission, and I just wanted to spend a few minutes talking about this because it's probably the area that we've spent most time on and which exemplifies our approach of improving interventions or understanding interventions, and also bringing together researchers across different mental health areas. And so the idea behind active ingredients is that we're interested in the aspects of interventions that are actually making the difference. So what are the core components, rather than looking across interventions and saying, you know, CBT or medication or exercise, what is it about particular components within those broad interventions that's actually making the difference? Are there particular people who benefit most? What's the state of the evidence on the mechanisms underpinning these interventions so that we understand best why they're working? In addition to the idea of ingredients being what's working, we also thought that this concept quite nicely exemplified the complexity within mental health, particularly for anxiety and depression, in that there's not going to be any one size fits all approach. These are very etiologically complex disorders, they're very heterogeneous, and the interventions that work for one person are not going to be those that work for everyone. So this active ingredients idea was getting across this concept that people should have the agency to craft their own interventions based on the best evidence of what's working. I'm not going to read out all the ingredients in this table, but for the 2020 Commission, we commissioned 30 reviews on 26 active ingredients suggested by researchers. And we've organised them here into ones that focused on depression and anxiety together, which was actually most of them, which makes sense because it seems that much of the research has looked at these transdiagnostically or applied to both. A few that look specifically at depression and anxiety. And you can see that they span the entirety of the sort of levels of explanation, right from biological, such as mechanisms of antidepressant action, to cognitive, repetitive negative thinking, developing helpful thinking patterns, to social and interpersonal, so social connection, for example, right through to larger societal organizations, so things like cash transfers or access to urban green space. And we're by no means saying that this is exhaustive, and indeed our 2021 Commission is specifically aimed at filling in some of these gaps, but I hope it gives a flavour of the breadth of our approach. So here's a few of the researchers that were involved in the Commission, just showing again the breadth. So we say from cellular to societal, and then from individual to interpersonal. And what we did was that we brought researchers together every month to discuss key questions related to the reviews that they were conducting, share problems, problem solve, and look at contextual similarities across the ingredients. And for many, this was a new way of working. It was a lot more collaborative. It allowed people to expand their network. And for many, it was also the first time that they had involved young people with lived experience in their research, and certainly in their experience of preparing a review paper. For many, this was a very new concept. What did we learn from this exercise? First of all, I think we were all surprised when we asked researchers to focus in on the nitty-gritty of specific ingredients. There was actually relatively little research that was directly relevant to particular ingredients and was focused on the 14 to 24 age group. For me, this was surprising because as an adolescence researcher, I obviously have a sort of availability bias, and I think everything is about the adolescent age group. But actually, in the context of mental health intervention research, there was less in that age group than we might have thought. And this meant that many of the conclusions drawn were extrapolated from studies involving older age groups. There was also very limited evidence on context. So even if there were good quality studies that showed that a particular intervention or ingredient was effective, there was very little on whether there were particular types of participants that it was best suited to, whether there were any cross-cultural effects, gender effects. So very little on tailoring. And even those trials that did exist to show efficacy often were underpowered. Yep, it was hard to search the literature by things like geographical context, culture, ethnicity, or age. And studies tended to be poor on the detail of implementation characteristics. So they would describe the method in a lot of detail, but when it came down to the intervention itself, what the participant had to do, how often they had to do it. Often that was lacking. So that also makes it hard to make inferences about what exactly is it that's the key factor in improving outcomes. And then finally, there were many interventions that targeted anxiety and depression as a whole, but they weren't necessarily targeted at particular stages of intervention. So there might have been studies aimed at prevention and then treatment, but there weren't so many that looked at, for example, stopping relapse or managing ongoing difficulties. We also found that the conceptual frameworks were sometimes overlapping. So we had ingredients such as hopefulness and goal setting. And actually, when the researchers came together and discussed their search terms and looked at the research that was coming up for their reviews, they found there was actually quite a lot of overlaps, and that's not something they would necessarily have thought starting out. And then another advantage of bringing everybody together was that links were made between seemingly diverse active ingredients. So, for example, a very biological ingredient such as reducing inflammation, turns out that things such as social connection were very much related to that. And so really trying to make those links, I think that was a strength of the Commission. And then I've got another couple of examples as well. But in the interest of time, I will say one of the strengths of the Commission was including young people with lived experience. They often changed the way the ingredients were defined. So, for example, we had a review on neighbourhood social cohesion, and it was the young people who suggested that the definition should also be expanded to include online groups. And that's particularly important and pertinent as we went through 2020 and that became more important. One thing that perhaps shouldn't have surprised us, but came out really strongly, particularly from our youth insight analyses, was that young people really valued agency, flexibility and personalisation. And that was often as important, if not more so, than the specific intervention content. And as I mentioned before, the young people also helped to identify gaps that will be covered in the next Commission. And yes, I've also spoken already a little bit about how the researchers themselves really valued the chance to collaborate and speak with people across different disciplines. So for more information, I've got a blog post here, blogs from our researchers on their findings, and these are now starting to filter through into research publications. So there's a couple already out in Lancet Psychiatry and Translational Psychiatry, and we'll hopefully soon have on our website a full list of the publications so you can see what we found. The second work stream, Unleashing the Power of Population Data, this is based on the problems that current treatments are accessed by only a minority of people who suffer from anxiety and depression symptoms. And those treatments that do exist don't help everyone. And we know little about what works for whom, so that personalization. And the data sets that currently exist wouldn't necessarily tell us the answers to those questions. So because of the way research is typically organized, researchers have to rely on small, sparsely sampled, labor-intensive data sets. So of course there are cohort studies, but they are few and far between and not necessarily always focused on mental health, or if they do have mental health measures, they tend to be quite sparse. So one of the aims that we've been working towards is developing our own data bank that we can tailor specifically to these questions of what helps prevent or address anxiety and depression symptoms at a more granular level. So it's sort of trying to combine the advantages of sort of experience sampling type surveys with a cohort study. And seeing at the moment in a proof of concept study, we have commissioned an external company called Sage Bionetworks to develop this idea and pilot it in 3 countries, UK, India and South Africa, and see whether it's possible to do a sort of mobile phone mediated data collection. So some of the data will be active, so young people deliberately answering questions. Some of it will be passive data collection that you can just take from a mobile phone. But crucially, we want to make sure that the young people are fully engaged and empowered in the data that they share with us, that they're aware of what they're sharing, that they have flexibility over which aspects of the data they share, and also that the young people ultimately could become citizen scientists and involved in the governance of the data bank. So there's quite a few different aspects of the data bank that are sort of novel proof of concept. And so we are still in the piloting phase, but we hope that if it is effective and works, and then we can scale it out, and it might provide a rich data source for mental health scientists internationally. But in the meantime, that's obviously quite a long-term project. In the meantime, we are working on improving access to current data sets and seeing if there is the possibility to improve inferences and conclusions that can be drawn from existing data. Coming hopefully January 2022, we will be launching a data prize in mental health. We've been collaborating on this project with another team within Wellcome called the Data for Science and Health team. So again, trying to work across different aspects of Wellcome to try and solve our problems. And again, we've commissioned external partners, in this case, organizations, Social Finance and DataKind. And the idea is to curate a data prize. And for those who aren't familiar with the concept of a data prize, it's quite a different way of working from a grant call, for example. The idea will be that Social Finance helps to curate data sets. At the moment, we're thinking across UK and 1 low and middle income country. And then we will invite researchers across different disciplines to come together and work on that data to answer a question around interventions for youth anxiety and depression. And we're deliberately keeping the focus quite broad so that the researchers can come with their questions, and Social Finance will also provide a sort of matching service. So there'll be, before the prize commences, there'll be a chance to, for example, if you have expertise in data science, but you don't have the mental health expertise, we might be able to help bring people together. And then once final teams are selected, then there will be an 18-month or so period to work on the data. And then those solutions that are judged most useful or the best at the end will receive a financial incentive. I quite like this idea that a data prize is like hosting a dinner party. So you need to serve the best food, so provide data that's relevant to the problem, invite the right people, have a seating plan, facilitate interactions, and then create an enjoyable environment so that guests will leave happy. So you provide incentives, but also support people throughout the challenge. So again, it's a more collaborative way of working, both for the researchers, but also for the funders, because we would be playing a more sort of hands-on role in organising the challenge. Another difference between a data prize or challenge and a typical grant call is the outputs that we'd be interested in. So we're not particularly interested in only research papers as an output. Research papers are great, and it would be great to have those alongside, but that's not the only output that we'd be interested in. We're also not interested in creating another mental health app, for example, because there are so many of those. And likely that would rely on collecting additional data to make it usable. What we're interested in is what insights can be gained from the existing data, and can we produce, in addition to research papers, could we, for example, produce models or algorithms that might be useful to other researchers, software packages, digital tools at the proof of concept stage, and just as a few examples of things that might be potential outputs. You might end up with a tool for young people to help them predict what might work for them, or you might end up with a tool for a clinician to help in a clinical environment to help to predict what might work best for a client, or for the mental health researchers, as I mentioned, you might end up with models or algorithms that might be helpful to the field as a whole. And as I say, we're really interested in the ingenuity and creativity of the field to come up with potential ideas. And also, well, my understanding is that social finance will bring data sets and curate data sets, but other researchers who have additional data sets will also be welcome to bring those. And finally, our third work stream, bringing vital funding and advocacy to mental health. As I mentioned, this isn't directly my area, but I thought I would mention it anyway, particularly because we have a funding call out at the moment, which might be of interest to some. So our main issue that we're trying to solve is that mental health is a growing area in terms of awareness. But largely those that awareness has been around what is mental health, and can we reduce stigma, and can we improve access to mental health services? And all of those are really important. But what we don't have really is an understanding that mental health research needs funding in the way that other areas of health research need funding. So there's little tradition of philanthropy or public funding in mental health, and it's quite difficult to get the public or large organizations to donate. So we're trying to raise awareness and improve the state of funding in several ways. One of them that's probably been the most publicized is capitalizing on workplace opportunities. So industry is particularly interested in improving mental health. And so we've been working with WEF and WHO to produce guidelines on workplace mental health. And we also commissioned several reports on what works best to prevent anxiety and depression in the workplace. We've also been working with UNICEF, WHO and WEF to develop a position paper outlining our mental health principles, to try and really get across this idea that lived experience is important. We need local innovation. We need to include low and middle income countries, and that mental health is larger than healthcare. It affects every aspect of political decision making, for example. I'll tell you a little bit about our workplace mental health request for proposals just before I finish up. As I mentioned, we ran one commission in 2020 and we're running another one in 2021. So they're aiming to commission up to 20 research reviews to look at the evidence behind essentially active ingredients, but as they relate to the workplace. And as with our active ingredients commission, teams will be asked to work alongside those with lived experience. And we're interested in applications from different global locations and different career stages. Particularly interested in low and middle income countries and those who may be underrepresented, and also early career researchers. So if you're interested in applying, if your work touches on workplace, please see details of the RFP on our website, and we actually have a webinar coming up next week. So please do register for that if of interest. So just to summarize, Wellcome are expanding our focus on mental health research. The discovery research part of research programs will fund basic research in any area of mental health, but not interventions. And then the mental health challenge area will focus on anxiety, depression, and psychosis, and will focus on that translation from the discovery side right through to implementation and scaling. In the meantime, while the challenge area is getting going, please do engage with the projects that are going on in the mental health priority area, such as active ingredients, common metrics, the data prize, and workplace. And our ultimate goal is to improve prevention and intervention over the next 30 years or so that fewer people are held back by mental health problems. Thank you.
Thanks very much, Kat. That was really excellent and comprehensive. If you can stop sharing the screen, I'm able to better monitor if people put their hands up, and you can put questions to the chat as well. I would also, before I start taking questions, I'd like to remind everybody that there is an early career event on 7th of July between 10 and 12, and we'll be advertising this. So please encourage your PhD students and postdocs to participate, or anyone who's a kind of an early career faculty member, very welcome to this event as well. We'll be advertising it. I wanted to highlight that, as this is the last seminar before the summer break, and we'll pick up again in late September. And again, we'll be posting the next term's upcoming seminars to the Eventbrite pages, and we'll also be sending information about them. But anyway, I think now it's good time to put questions to the chat. If I may start by asking a few questions, and then I will pick up anything that's from the chat, or put your hands up. So I was wondering whether with your new programs, there are any plans to encourage team science. So you have talked about the importance of doing interdisciplinary mental health research, but I think that traditionally what is a bit of an issue with research funding is that there is a slight sort of cult of PI, where the only person important is the person who's nominated as a PI in the funding. And that, I think, reduces incentive for other people to contribute perhaps to the you know, as much as they would otherwise. And I'm wondering whether there are any plans to structurally change a little bit as to how, you know, these grants are rewarded. Is it something you've considered, or you would be open to considering? So if you want to encourage people working across disciplinary boundaries and really putting their all into these projects, is there a way of recognizing multiple co-PIs as opposed to just having this PI model that is so prevalent, and I think is probably not hugely healthy for science?
Yeah, I completely agree with that, and it's something that we are considering quite carefully. As you say, partly so that we can encourage people across different disciplines, and also so that we can encourage international teams where, for example, partners from low and middle income countries are equal partners on a funding bid. So yes, that is an idea that we're thinking about. We're also thinking about ways in which we might facilitate interactions and build collaborations in advance of the grant application process. So I think, you know, often a grant call comes out and there's a sudden scramble, or you've only got 2 months to submit something. But we're trying to look at models where we could perhaps increase the length of time, work with researchers to help build partnerships. So I think there's a lot of different models that we're looking at the moment, and we're definitely open to, I think now is the time to really take that feedback on board and think seriously about what are the structural issues in the way grants are funded that are preventing this kind of science that we would like to see. Right.
So there are a few questions in the chat. One from Jess Dayton is, what is the most surprising, or what are the most surprising findings that have emerged from the active ingredients work so far?
I suppose I was quite surprised about how small some of the effect sizes were for some of the interventions that you'd have thought would be quite quite effective and you hear quite a lot about. So for example, there's one on cash transfers where the effects were very small, but they were very consistent. So I think, you know, it's really made me realize that you can't put all your eggs in one basket. You have to take this sort of scattergun approach because the effects are going to be quite small with any interventions. What else was surprising? I'm sure there are many, but they've just escaped me for now.
Yeah. Well, you can come back to it if you remember. There's a question from Matt, which is, how often do you expect funding calls to be announced? And how much funding is there to support this challenge area and over what time period? So I understood the time period is 30 years, is that correct? But how much and how often will the calls come?
So I'm really sorry, I'm afraid that I just can't speak to that at the moment because it's all being developed right now. And I really wouldn't want to say anything wrong.
In terms of the sum, do you have the sum of funding finalized or no, even that?
No. But I suppose we are hoping to have more information out to the field in early 2022. So yeah, that's, I'm afraid, all the detail that I can give at present on that.
Great. Okay, there are a few questions from Lamia, which is, regarding the local innovation, would this apply to researching local contexts versus those at the national level? For instance, are local contexts within the UK also a priority, or is the priority focus at national level, so UK versus somewhere else, for instance?
So is that a question about whether, sorry, I don't quite understand.
So I guess the question is that if there's a focus on different localities, is that only comparing different countries, or is there also, if I've understood this correctly, is there also focus on perhaps different areas of UK and how these may provide different environments?
Yes, I think that would definitely be in scope. If you made the case that there was a strong reason for looking at particular localities, yeah, I don't think we've got a strong reason.
And there's another question from Lamia, which is, while the approach of active ingredients is appreciated, would we be doing justice to look at common metrics and standardizing outcomes in view of the sort of the contextual approach? So again, if I understand this correctly, it's sort of, is there a bit of a tension between trying to have these standardized metrics and then trying to understand individualization, which, I mean, if you kind of take some of the active ingredients findings at face value, it seems that, you know, different things work for different people, which is probably in part responsible for why the effect sizes can be quite modest. So
yeah, so I think it's important not to be too stringent about metrics. I think that's why we focused particularly on these three for measuring outcomes. I think we definitely wouldn't be looking at standardizing a whole host of measures in other areas. That's my understanding of the question.
Yeah, so essentially what you're saying is that you welcome sort of diversity in trying to understand mechanisms, but you would like to see these standardized outcomes included so that you can have some comparability across different studies that might be focusing on very different mechanisms. Yeah,
absolutely. But we're interested in what measures have been used. For example, in the active ingredients, we asked our researchers to consider, you know, what are the gold standard measures for the active ingredient that you're looking at? What are the gold standard interventions? You know, how are they quantified? Which is one of the reasons that I mentioned we weren't, you know, the studies weren't always as detailed as they might have been on the exact content of the intervention and how it was operationalized.
Yeah. There's Tobias House is thanking you for nice talk and was asking, could you elaborate more why you focus on anxiety, depression and psychosis, and these are already the most prominently funded disorders, and it puts other more common disorders at risk to be further left behind even more. And I have to say, I mean, I obviously have an axe to grind here as well. You know, you have conduct problems that pretty much their impact is comparable and just almost never get a looking in terms of the funding. So is there, and given the sort of diagnostic revolution that seems to be very much on its way, what's the thought behind focusing on these three as opposed to being a bit more open?
Yeah, I completely take that point, especially as a conduct problems researcher myself. I do take that point. I think first of all, worth mentioning that you can still apply for funding under the Discovery Research programme for other disorders, although admittedly not so much the intervention studies. But I think there will still be quite a lot of scope within the Discovery Research schemes for more general mental health science research. In terms of why we're focusing on anxiety, depression and psychosis for the challenge area, I would say this is very much in the first instance. This isn't set in stone for the next 30 years. I think the reason that we are focusing on them is that they are common disorders by some metrics, the most common worldwide, and also those that have a high global burden of disease. So yeah, I completely take the point that there are other equally worthy disorders, but for the moment, in the first instance, that's why we're focusing on these, and also because we're consolidating across existing programs, so mental health psychology, mental health priority area, and other areas that have been focusing on those already. So not saying those are set in stone forever, but those are where we're focusing in the first instance.
Okay. There's a question from Sarah Griffiths. She's also saying thanks for the talk. And she's asking what steps Wellcome are taking to make sure that the needs of young people with neurodevelopmental conditions are represented, given they are not always able to express their needs and views in mainstream ways. So that's from Courtney Norbury and Sarah Griffiths.
I think we haven't specifically looked at that target group. However, our lived experience lead has a background in disability rights and is working hard to ensure that all the young people with mental health problems, with lived experience of mental health problems, are represented. So yeah, I don't have a direct answer for neurodevelopmental conditions, but I'm happy to put you in touch with Kate Martin and she can discuss this in more detail if helpful.
Great. I don't see currently any more questions in the chat. Is there anyone who would like to ask a question in person? No hands? Okay, I'm going to give it a few more moments, but if there are no more questions in the... Oh, John Royce has raised a hand. Go on, John.
Hi, Kat. Thanks very much. Really important ideas going forward, and it's really nice to see the long-term view as well. I've been wondering about how hard the distinction is between the sort of basic science area and the mental health priority area. During the talk about a month ago, which Wellcome did on the new schemes, I got the impression that basically they were saying that they wouldn't fund clinical trials under that banner, but everything else might be within remit. But so, for example, trying to understand how an intervention worked. So how does an antidepressant work, for example, might be interesting for me. But from your talk, it sounded like that was going to be quite restricted to the priority area funding. So can I just ask, how hard the distinction is, and whether you think mechanistic research into how treatments work is actually fundable via the other route, or whether it's really only through the priority area. Because if it is, then actually Tobias's point is a very good one. We literally could not try to understand an OCD treatment through Wellcome, full stop, right?
And I had the same concern regarding conduct problems.
Yeah. So I don't want to speak for Discovery Research, but my understanding is if they've said that, then that is the case. It would be that in addition, we would also be able to look at it via the challenge area. But I think this is definitely something that we have explicitly discussed, that we want to make sure that, you know, as much mental health research as possible can be funded, but also not unfairly giving an advantage to some researchers by saying, oh, you could actually apply for this via 2 routes. So we are definitely aware of this question, and we are still working it out. But yeah, thanks for raising it.
I think it would be really good to get some clarity before any calls are announced, because, you know, at the moment I've got a study that I'd love to apply for when the new call opens in November, but actually I genuinely don't know whether it's going to be considered eligible through the basic science scheme or not, because it's about trying to understand an intervention. And then a kind of follow-up question would be the extent to which, and this was actually asked at the other meeting, but I don't think the answer was very satisfactory actually. Where does public mental health sit? So is the basic science scheme going to fund public health type research, looking at cohorts and epidemiology, you know, and you can do some really important work around causal pathways there, or is that really for the mental health priority area?
So again, I don't know 100% for discovery research. I think for us, certain types of public sort of cohort research would be in scope for us, particularly if they shed light on potential interventions or on mechanisms that might underpin interventions.
Great, thank you.
Very closely about.
I guess what I'm hearing sort of between John and Toby and also myself is that there is probably something we'd like to feed back to Wellcome, which is that, you know, mental health research for a very long time has been the poor relative of health research. And I think there is a concern that there may now be particular conditions that become the poor relative within the mental health research. And I think in the light of the, you know, the recent work, for instance, from the Dunedin cohort, where if you look at the longitudinal sort of progression of various mental health conditions, you know, people shift between diagnoses, they have endless comorbidities. And I think I can see the sort of, in one level, the desire to try and kind of fence the problem a little bit because it's so vast. But I do think that there is a genuine concern, at least among researchers on this meeting, that this may end up having unhelpful consequences. So I don't know if you can feed that back, and we would be very happy to feed it at a round table or something if necessary. But
we'll definitely feed that back. Yeah, and there will be other opportunities for the research community to feed back to us as well.
Yeah. Alexandra, I saw your hand. I don't know whether that was a mistake or whether you wanted to ask a question. Alexandra Pike?
Oh, I don't think I raised my hand, sorry.
I think there was a hand raised, but it might have been a missed
okay, sorry.
Button, so that's fine. It went away. Any further questions? No? Okay, I'm sure that Kat would be perfectly happy to answer questions via email if anyone has a sort of late revelation or is feeling too shy at the moment. But I would like to take the opportunity to really thank you, Kat, for taking the time and giving such a helpful talk. And I'm sure we'll all be watching that space and as things develop. So I would like to invite everyone to clap hands, either virtually or otherwise. And hopefully we'll all be able to take part in that exciting program of research as it comes out. So thank you very much, and thank you everyone for attending, and please come along for the early career event, or make sure that your early career researchers know about it.
Thanks, Jessie. Thanks for having me.
Kat, have a look at the chat. There's lots of thanks to you. I think you want to take a
Thanks. So nice to see so many familiar faces.
Yes. Great. Good. I'm the host, so I'm just waiting for everyone to disappear. John, actually, John, do you have 2 minutes? Can you stay?
Oh yeah, that's fine.
And then I'm going to stop recording actually right now.